Thanks to all the audience who follows our broadcast. Well, we have the honor today of having Dr. Jacques Morcos. Dr. Morcos is co-chairman of the Department of Neurological Surgery, professor of clinical neurosurgery and otolaryngology at Jackson Memorial Hospital, director of a school-based and endoscopic surgery and cerebrovascular surgery programs. Now, at the 2021 IWBNC, Dr. Morcos is going to share his lecture titled Bypass Surgery for Moyamoya and Cerebral Ischemia, Flow Dynamics, Technical Variations, and Outcomes in a Large Series. Please type write your questions in the Q&A panel. We will read them at the end of Dr. Morcos' intervention. Dr. Morcos, welcome again, and thank you. It's all yours.
Thank you very much. Can you hear me well?
Yes, sir, we can hear you perfectly.
Thank you. So again, my pleasure to be part of this great series. I enjoyed doing it last year, and thank you for inviting me. So I'd like to talk to you about recent data from my experience with bypass surgery for Moyamoya and steno-occlusive disease. It consists of my personal series of 162 cases. My disclosures are irrelevant to this. This material is a manuscript being submitted, and that's what I'd like to summarize what our findings are. I wanted to look at how we're doing, at least in my experience with Moyamoya disease, Moyamoya syndrome, and atherosclerotic steno-occlusive disease. I wanted to validate the use of the direct ECIC bypass and evaluate predictive power of intraoperative flow measurements, as well as look at long-term bypass patency, clinical and angiographic outcomes. I looked at my last 21 years of practice. We, of course, excluded all cases of aneurysms and tumors. This is just ischemia. I utilized 3 different bypasses, direct bypasses, 3 different anastomoses. I am calling them 1D, 1R, which means 1 donor, 1 recipient from the STA. Sometimes 1 donor, 2 recipients. So from the same branch of the STA, we can get 2 anastomoses, 1 side to side and 1 end to side. Or the so-called double barrel anastomosis, which is 2 donors, 2 recipients. Those are the 3 types I used. I like to keep it simple. Usually it's an incision like this with a craniotomy 6 centimeter above the external auditory canal, so you can access the distal sylvian fissure. Let's start with a typical example. This is a 32-year-old female. She actually is a nurse in the neurology unit, and she was having right-sided weakness and dysphasia, and her MRI showed right anterior frontal infarct. She had treated hyperthyroidism. Here is an angiogram showing typical Moyamoya disease in the distal ICA. You can see her attempt at collateral formation from the left MCA and from the left posterolateral choroidal to the left MCA and to the anterior choroidal, and the PCA to the ACA and MCA. Here is the external carotid injection. And we like to do here at the University of Miami with our colleagues in stroke neurology, we like to do vasomotor reactivity analysis by transcranial Doppler. There's a very simple formula, but it involves transcranial Dopplers and the hypocapnia and hypercapnia, and the normal number should be 70%. Her numbers were 27%, very low on the right side, and 32% on the left hemisphere. We did the SPECT with Diamox, but this is an older case, but nowadays we do CT perfusion or MR perfusion. She had very diminished perfusion with the SPECT with Diamox. That's my usual setup for bypass. I insonate both branches in case I need to use both. Here is a dissection, the craniotomy. Here is using the Charbel flow probe. I think Dr. Charbel may have spoken earlier today. This is a Charbel flow probe, which is very useful, of course, in measuring quantitatively the flow. I measured it to be 3.1 cc per minute, this recipient cortical artery. I then measured the STA cut flow. When you cut the STA, how much flow? It's 60 cc per minute in this case. Then I proceeded with an anastomosis. I like to do it in a running technique usually, unless the artery is very, very small, meaning 0.6 millimeter or less. The completed bypass, and I measured the flow again. Remember, the cut flow was 60, and after I finished, it was 64. So this is an excellent so-called cut flow index of more than 100% when you divide the bypass flow at the end by the cut flow. And you can measure how this flow is diverted, how much goes proximally, how much distally. This is a post-op CTA, shows a patent bypass. A few weeks later, here's a patient doing very well. A few weeks later, I proceeded to do the bypass on the other side. And that's the angiogram after both bypasses. So that's a typical case of Moyamoya. How about atherosclerotic steno-occlusive disease? As you know, the COS study 9 years ago said that there is no role for bypass surgery for carotid occlusion. We, of course, many of us disagree with that statement. We cannot agree that it's a true blanket statement, that there are many patients properly selected who would benefit from the study. This is a typical patient. He was 76 years old at the time. You can see the watershed infarct in the right hemisphere, and this man was having daily multiple TIAs every day for several weeks by the time he came to me. This is his cervical carotid occlusion on an angiogram, no good collaterals from the ACOM, and very little from the PCOM. So this case, this patient really deserves a bypass because he is already has a stroke and he could have a very large stroke. We did the SPECT scan with Diamox, and you can see in the white circle the misery perfusion and the paradoxical steal to the other hemisphere. And the VMR in him was very bad, 19%. That's very low. The other hemisphere was 55%. I did the bypass, single barrel, 1D, 1R, and you can see the size of the STA. Here is his post-op CTA. And this man has had no TIAs for 10 years. Then he died at age 86 from a heart attack, MI. So it clearly works, the bypass, when you in ischemic disease, when you select the patients appropriately. So what did I do in my study, in the review of my series? I looked at all of these things: severity of disease, suitability of the donor, degree of collateralization. We looked specifically if the collateralization was compensated or not. Was the area of hypoperfusion compensated or not? Here is what I mean. These are the 3 types of collaterals you can have when you have ischemic disease or Moyamoya. You can have transdural collaterals, like the top left. You can have retrograde via the PCOM and leptomeningeal collaterals, or you can have cross-flow across the ACOM. So when we look at a case, we analyzed every case that we could have angiograms on reviewed. We overlapped all the angiograms that we had, all the injections on that given patient, and we decided if there was an area of hypoperfusion that did not have compensation, such as this pink area. This is the posterior circulation, anterior circulation overlapped. we looked at that. We looked at, of course, bypass patency. We look at Matsushima grading A, B, or C in the post-op angiographic analysis. This is a typical mature bypass a long time after the surgery. You can see how large the STA gets. You can see a typical bypass 11 years after surgery. First, the pre-op at the top. You can see 3-month post-op in the middle, and then 11 years post-op CTA at the bottom. This is an example of a bypass that occluded 2 days after surgery. You can see the occlusion on the left angiogram. So I took him straight back to the operating room and revised the bypass. There was a problem with the recipient artery, so I chose a different recipient, and you can see now the bypass is working in the bottom right image. There are cases that have delayed asymptomatic bypass occlusion when you follow them for a long time. Usually it's because they develop indirect collaterals. This is what such a case would look like. You can see the anterior STA branch that was not used in the bypass. You can see the anastomosis site that is not patent because, or even though it was patent early post-op, and you can see the indirect but robust capillary blush from transdural collaterals that have taken over, and which I believe is the cause of the direct bypass closing slowly. And that has been demonstrated in other series. As I told you, we've looked at TCD VMRs, and these are the ranges at the bottom that you can see: normal, mild impairment, moderate impairment, or severe impairment. You can also do something called breath holding index with TCD. It's a different way of analyzing the same thing. We've looked at the post-op visits. We've looked CTA, MRA, or DSA. And here are the results of 124 patients. They underwent 162 procedures because 72 patients had bilateral disease. My mean range of clinical follow-up is it's almost 3 years. My longest follow-up is 21 years. My longest angiographic follow-up is 12 years, mean of 1 year, 9 months. Of course, earlier in my practice, I was doing less surgery. So my first the first 7 years of the study, I did 14 surgeries. The next 7 years, I did 41. And the last 7 years, I did 107 surgeries. So here is how I grouped them. Moyamoya disease, Moyamoya syndrome, and steno-occlusive disease. So you can see the range of ages. You can see that the SOD, the steno-occlusive disease patients, of course, they were older. They had atherosclerosis. You can see the different races, presentation, and of course, these are busy slides just to show that we looked really in detail at the comorbidities of every patient. And we've analyzed that modified Rankin score pre-op and, of course, post-op. We've looked at the angiograms, CTA, and all the studies available. Of course, the vessels that were mostly involved were the ICA, then the MCA, and vertebral artery in 2 cases. We graded the stenosis moderate, severe, or occluded. And we looked, as I said, at post-op Matsushima grade at last follow-up. And of course, bypass patency. You can see that the VMR, mean VMR pre-operatively was very poor. It was 29%. So that tells you that hopefully I have been selecting appropriately the patients for bypass surgery and not doing unnecessary bypasses. Post-operatively, this happens in most series. The VMR, in spite of a very successful surgery and resolution of symptoms, the VMR doesn't usually become normal. It's about 39% compared to 29%. So that does not indicate that the surgery did not work. This is a Spect analysis. We'll skip that. Here is the intraoperative information. I did 1D, 1R, single barrel in most patients, but more recently I have been doing 1D, 2R, and of course I've been doing 2D, 2Rs before that as well. The donor is STA, but when you don't find an STA, you can use the occipital artery to the angular artery bypass. You can use the posterior auricular artery. I've done that in 2 cases. Type of suturing, I usually do continuous running suture, sometimes do interrupted or a mixed of interrupted and continuous. The SSEP, the somatosensory evoked potentials, please notice, they essentially never made a difference. So now I don't use them anymore after analyzing my data. It's a waste of time to do SSEP monitoring because it was unchanged in 159. They got better in 2 patients, and it only decreased transiently in 1 case. So it's a waste of resources to do it on a simple STA-MCA bypass for ischemia. The cut flow mean was 52 cc per minute, and the total final bypass flow was 44 cc per minute. It means the cut flow index was 0.86 average, which is very good, quite high. What was the surgical morbidity? So when you look at 30-day morbidity, there was significant morbidity in 10% of the cases. What was the morbidity? Ischemic stroke, only 1 case. So 0.6% had an ischemic stroke from the surgery. 3.1% had a hemorrhage, intraparenchymal. Not all of them required evacuation. Only 2 of them required evacuation. Then subdural hematoma, acute or chronic, in 1.9%. Some wound complications, 1.3%. Respiratory failure, and MI. If you add all of these, you get 10%. But looking at ischemia or hemorrhage together, this is 3.7%. I want to remind you that in the COS study, that morbidity of ischemia or ICH was 15%. So it's a big difference. I don't think I have time to analyze each of those complications, but we have them, and it will be in the published written paper. But we, of course, go over each complication to try to understand. And I don't think I'm going to go over these 6 cases right here. Here is one important finding from the study. If there was complete collateralization pre-op, 36% will have a delayed occlusion of their direct bypass without symptoms and remaining neurologically improved. If there was incomplete collateral formation pre-op, the patency rate was much higher, 96%. So that is very significant, and that is the main significant difference between the ones that occluded and the ones that did not occlude. I'm talking about delayed occlusions. I'm not talking about acute occlusions. We only had, as I said, 5 acute occlusions. And here is in graphic form the effect of collateral formation, incomplete versus complete, on delayed patency. The orange graph is incomplete collateralization. This does not mean, however, if I can go back to this slide, this does not mean you should not conclude that if somebody has complete collateralization that they don't need the bypass. Because remember, these patients had abnormal VMRs and were having symptoms. It simply means their individual biology allowed them to have some collateral formation, but that was probably more robust than other patients who did not have it. But once you put in the bypass, you created a craniotomy, perhaps under the effect of VEGF, or other factors, their indirect collateralization increased and made the direct bypass less necessary. That's how it should be interpreted, and it should not be interpreted as that these patients don't need bypass surgery. Clinical outcomes, we had significant improvement in modified Rankin score. You can see pre-op in blue, post-op in orange, those shifts to the left. And here is a comparison of the three techniques, 1D, 1R, 1D, 2R, and 2D, 2R, analyzing all the factors. There is nothing statistically significant between them. Maybe it will be significant when I have more numbers in the 1D, 2R, but you can see there is a trend of better cut flow index with the more anastomosis you do, from 0.74 to 0.98 to 1.07, you can see a trend for improved long-term patency rate, but that's just it, a trend, not statistically significant. Now, we looked at the delayed occlusions, and the only two factors, one of them that I don't think makes any sense and perhaps is pure chance, is Hispanic race, seem to have higher incidence of long-term silent asymptomatic bypass occlusion. The other factor be it collateral formation that I discussed. Of note, CFI, cut flow index, did not make any difference on long-term patency, and I will show you the numbers a little bit later. Let me show you a video of a 1D 2R bypass. The video was edited by former fellow Georgios Zenonos, who is now in Pittsburgh. Here is a typical Moyamoya patient. Here is the surgery, and I will run it a little bit. We like to, I like, particularly as I train fellows and residents, I like them to do the opening under the microscope. We like to use what I call the Colorado needle, the Bovi you saw earlier. I like to use also the bipolar in this manner to do a quick dissection of the STA. I measured the cut flow after cutting this STA. It was 50 cc per minute. And this is ICG videography. And then we're going to do the craniotomy. I'm going to fast forward through that. You cut the temporalis muscle, you turn the bone flap, and then you dissect. In this case, it's a 1D 2R. This is a suction device. I need two recipients, one on the temporal M4 and one on the frontal M4. You may sacrifice small, tiny branches coming off those recipients to allow room for the temporal clips and the anastomosis. I do my measurements of flow, 4 cc per minute in that direction on the right, 2 cc per minute in the other one. I do ICG, and then I mark the recipient, and then I'm using 10-0 suture to do, in this case, I did the end to side first. In most of my 1D 2R, as you will see later in the data, I do the side to side anastomosis first, because it makes more sense to do that, to allow the flow through that anastomosis while you're doing the next end to side anastomosis. I like to do the arteriotomy with the beaver blade, or sometimes I use a disposable knife that is very sharp. I like to anchor the 12 o'clock position first, and I don't usually anchor the toe, the 6 o'clock position. I know some of my colleagues would anchor the toe. I like to leave it this way and do either interrupted, particularly if I'm training a resident or a fellow. If you do interrupted, you can get to suture more. Or if I'm doing running, I run it, and without anchoring the 6 o'clock position, the toe. You do one wall, and then you do the other wall. I'm speeding through that. Now I'm going to measure the flow. I release my temporary clip. Remember, the cut flow was 50 cc's. This flow now is 43 cc per minute. So then I proceed with the second anastomosis. Here is how you do it. This is a side cut in the STA, and you have to make sure you clamp again the bypass to be able to do that, which is why it's better usually to do it the other way around. Do the end-to-side first. So now we're going to put heparinized saline, and of course here it's a side-to-side, so you have to do the back wall first, unless you can flip the STA, and then it doesn't matter if you can flip it. But if you cannot flip it, if you are fixated like this, you have to run the back wall first, meaning you place a suture like this at the 12 o'clock position. I like to use a curved needle holder. And when you tie this, you have to pass the needle behind the knot in order to run it out in. Because if you don't do this, you see that move is very important. If you don't do this, you will turn the knot inside the lumen. And if you're right-handed, you have to put out in on the left edge, and then in out, and then out in, and then in out, and that's how you run it. If you are left-handed, of course, you do the reverse. The important thing when you do a side-to-side is your final throw, the final thread should be on the outside when you're going to tie it. Again, if you leave it on the inside, your knot will be inside the lumen, and you will have a problem because it could form clot. So very important. There are many details about bypass surgery, but this is a very important detail. So I release all the clips, and I will measure flow again. And the flow will be more than the cut flow. The flow will be 60 cc per minute. So that's higher. So that's more than 100% cut flow index, which is normal, which is quite common when you do a double anastomosis like this. So that flow is divided 60 cc, 22 cc per minute went into the frontal territory, and 38 cc went into the temporal territory. The total is 60. I do an ICG, it's nice and patent. And here is a summary of all the numbers that I have described to you. And then you put the bone flap. Of course, make sure you don't occlude the STA when you close the skin. Here is a post-op angiogram, AP and lateral, and you can see both anastomoses are patent. So that's your typical 1D, 2R. I don't think I need to show you the full video of a 2D, 2R, but you can see it's the same thing, not the same thing, but here you're using both branches of the STA. I don't do this anymore, but if that is the only way to do it, you need to know how to dissect the frontal branch of the STA from under the scalp. And again, this Colorado needle is very useful. So now I'm going to speed through this. You get your two recipients, you make the same measurements, you do one anastomosis with one branch, you finish that. In this case, I'm doing running. And we do the other wall. When that anastomosis is finished, then the second anastomosis with the second branch. Exactly the same thing. Nothing new to learn from that. Same thing, running. So now this is a double barrel. You can see at the end, double barrel. And we are going to measure flow, same thing, and get the numbers and get an ICG. And that's a completed bypass here. I used occipital artery to Pica bypass for vertebrobasilar ischemia. I just show you briefly how that may look. Remember, posterior circulation ischemia is often not recognized. Look at this patient. You can barely see vertebrobasilar system. And this patient was having multiple TIAs of the posterior circulation. And we have a nice occipital artery to use. So you need to do a far lateral approach. You remove this bone flap, use the occipital artery to anastomose to the tonsillomedullary segment of the pica. So here is the Doppler of the occipital artery. Yes, of course, it is more tedious to dissect, but it's an important technique that you need to learn because it can save you. If you don't have an STA and you have an occipital artery, that is probably your only available donor. So we are going to do the craniotomy. I'm not going to waste your time with the craniotomy. Here is the dura open and opening the cerebellomedullary fissure, arachnoid dissection, and you're looking for the pica at the tonsillomedullary segment. Here are the lower cranial nerves. I will put a retractor to hold the tonsil, and here is a retractor, and now is the pica, which I am mobilizing to find a nice segment right here. Notice I'm looking for perforators, and I'm gonna pull the pica closer to me until I see the last major perforator right here. I don't know if you can see, I don't know if my indicator shows on the screen or not, but make absolutely certain you don't avulse the perforators of the pica. Here it is. You see, it's a significant perforator. So I cannot pull it any closer to me. And then you will do the end-to-side anastomosis. You measure the flow. You measure how long of the occipital artery you need. You cut it. And end to side, I am not going to waste your time with the anastomosis, but same thing, like for an STA MCA, same thing. It's of course a little deeper, but you can see there is plenty of room because of the far lateral approach. You need a curved needle holder when you do an anastomosis at the depth to be able to have 1 extra degree of freedom. At the end, here is a completed bypass. I measure the flow. I make sure it's good. And make sure when you close, you don't strangulate the occipital artery with the muscle or the skin. Here is the dura closed, of course, non-watertight to allow the occipital artery to go in and make sure the muscle doesn't stenose it. Here is a post-op angiogram. You can see the bypass is patent. I will skip this one. I had to use a saphenous vein bonnet bypass, meaning from one side of the head to the other because the STA was was very poor on the ipsilateral side because the common carotid was occluded. It's a rare technique to use, and I've done it twice. So this is to say that really direct bypass is very effective in select Moyamoya disease, Moyamoya syndrome, steno-occlusive disease. It seems that the incomplete collateralization on pre-op angiogram is an important indicator of delayed occlusion of the bypass. My patency rate is 91% long-term. It's 100% immediate bypass patency, but long-term was 91%. And as I said, all of the patients who occluded, except for one patient, in a delayed manner, occlude asymptomatically and remain asymptomatic. The cut flow index in my series seems quite high, but does not seem to correlate with long-term patency, which is in contradistinction to what Dr. Charbel and Sepi Amin Hanjani, my two good friends from University of Illinois in Chicago, this is contrary to what they found in their series. So I don't know why that is the case, why there is a discrepancy. But here is what I thought I would do. I would compare both series. So the UIC series, of course, Charbel and Amin Hanjani are the surgeons. My series, I'm the surgeon in my series. They had 146 cases in their 2019 publication. My current series is 161. I did more 1D2R and 2D2R percentage-wise than they did. So that may have something to explain it. But I think the main difference is that the UIC series utilizes concomitant EDAS as well as direct bypass. When they do their bypasses in more than 1/3 of the cases, they also put in the dura and perhaps the muscle. And I think that might explain why the following numbers, why 76% of their patients were patent direct bypass at long-term follow-up compared to mine of 91%. Perhaps because of the indirect bypass that they add, it makes the direct bypass less needed long-term. And you can see that in their series, a CFI of less than 50% predicted an occlusion rate of 54%, which is quite high. In my series, it was 11%, the CFI. So again, I don't have an easy explanation why we're getting different results, except for the fact that they use the concomitant EDAS as opposed to my series where I don't use it. And that's why I think the patency rate is in my series remains 91%, in their series is 76%. So that's a slide to try to describe the discrepancy. So over in my series coming back, please notice these very important numbers. I only had one death in it, actually in that bonnet bypass due to anesthetic complications. 30-day morbidity mortality of stroke and ICH was 3.7%. I remind you that is a lot better than the costs data of 15% perioperative morbidity mortality. And when I followed my patients long-term, overall, including the 3.7% perioperative morbidity, it's a total of 6.2% of stroke or ICH long-term. So that is, again, much, much better than not doing the bypass, because the stroke rate in the population that I'm operating on, if no surgery is done, can be as high as 82% over 5 years. So clearly, the bypass was indicated in most cases and was very helpful, and the patients improved. In my remaining time, I will talk about the sub-series, which is now, which has been accepted for publication recently in JNS, and you should see it coming out published soon. The 1D2R, I have now done more than 25 cases, but the series is the first 21 cases. And I want to use that series to tell you how really I learned a lot from just quantifying blood flow and using the flow probe during surgery. A quick reminder about the math and physics of bypass so that you can understand what 1D2R really means and why you get the flow measurements that you get with them. If you're going to do bypass surgery, you need to understand some basic stuff, such as Pythagorean theorem, because when you fish mouth the donor, you're making an hypotenuse instead of a side, and that increases the cross-sectional area by 4 times compared to if you don't fish mouth the donor. You need to understand a little bit the Bernoulli equation, but more than the Bernoulli equation, you definitely need to understand the Hagen-Poiseuille law that tells you it's exactly like electric circuit and Ohm's law. It tells you that resistance influences proportionately blood flow, that voltage or delta P is proportionate to flow and inversely proportionate to resistance. And therefore, to improve your flow, you need to decrease length and increase the radius. So to the power 4, the relationship is to the radius power 4. We've learned a lot from coronary bypass surgery, and a lot of work has been done there. And I'm not going to get you into I'm not going to waste your time with basic science research in that field. But what have we learned? We learned that the surgeon can influence the geometry of the bypass. We can try to influence the donor-recipient diameter ratio, but we cannot really control well the blood rheology or the morphology of the endothelium. The take-home message technically is that you should anastomose at a small angle. The smaller the angle, the better it is. You will get less turbulence, you will get less stagnation, you will get more physiologic wall shear stress, and your bypasses will last longer. It is important. This is too advanced, and I'm not going to pretend I can explain it quickly, but it has a lot to do with what happens to wall shear stress. I'm going to skip that. It is very important to realize that humans and animals and every biological being regulates wall shear stress. They aim at normalizing wall shear stress. So when you create a bypass, and let's say wall shear stress is high at the beginning, the vessels will adapt to try to reach a wall shear stress of approximately 15. Similarly, if you have low wall shear stress after your bypass, it will increase over time. You see in these two graphs, they tend to merge and converge because it seems that the constant that the body likes is a certain wall shear stress. And it differs between animals and humans and different species of animals. For us, for surgeons, it's important to have a short L, to have a donor to recipient ratio 1.5 to 2, fish mouth the donor unless there is a large discrepancy in the diameters of the donor and recipient. Try to keep the anastomosis angle low. Place your sutures closer at the toe and the heel. So when you do an end-to-side anastomosis, you really want to try to do the construct that's on the right, to fish mouth, because this is from a chapter we've written a few years ago. The cross-sectional area is 4 times bigger than if you didn't fish mouth. End-to-end anastomosis, try to bevel it, and side-to-side anastomosis, as I showed you in the video. And this is where I do my arteriotomy for side-to-side. So here is the data. Again, I thank Nick Khan, my excellent fellow, and many of the residents in the program that have helped put the data together. So the 1D2R data, here it is. I'm going to skip a few things because I've already explained it. But this is how it's going to look at the end. 1 donor, 2 anastomoses, 2 recipients, and you're irrigating 2 territories. This is, I showed you a video of 1D2R, so I think I can skip this other video. It was going to show the same thing. I remind you the mathematics behind why we're doing a double anastomosis, because the equivalent resistance of the entire circuit, it's a circuit in parallel, it's not a circuit in series. The total resistance is lessened. So it's, I don't know if you remember from high school, the total equivalent resistance in an electric circuit, 1 over R is 1 over R1 plus 1 over R2. So as you add resistances, you decrease the total equivalent resistance. I'm going to skip those collateral formation. And here are the steps when you do a 1D, 2R. You isolate both recipients, you measure the cut flow. You can see in the colored red vessels there, the cut flow being measured. Step number 2, you do the side-to-side anastomosis and you measure the interim flow. This is not final flow because this is flow after the first anastomosis. That's QI. I label it QI. Then you do your second anastomosis. Now you measure the total flow and you measure the final flow in each vessel, in each of the two recipients. Remember, the final flow in the side-to-side will often be different than the interim flow in the side-to-side because you created a new sink. And that's the data that I'm going to show you and what I learned about it. So here are the results. The demographics are probably not very important. It's, remember, a sub-series of the 162 cases. So bypass patency rate was 100% immediately and 90% on delayed follow-up. Notice the cut flow index. When I measured cut flow index after the first anastomosis, it was 0.64. When I measured it after the complete bypass, double anastomosis, it was 0.94. It went up because it makes sense that the resistance dropped. What really my data shows is that the overall donor to recipient flow increased by 50% by adding a second anastomosis. And patients improved, the modified Rankin score improved. Here is a graphic formation, a graphic depiction of the cut flow. A cut flow was 57 on average. The interim flow was 35, and then the final flow was 51. You can see it drops down and then goes up. It shows you the value and benefit of adding a second anastomosis. Here, when I first started doing this, sometimes I would do the side-to-side first, sometimes I would do the end-to-side first. I had the opportunity to see if there was a difference, and there was no difference, whether you do the end-to-side or side-to-side first. But of course, it makes more sense to do the side-to-side so that, as I said earlier, the flow through that anastomosis can carry on while you are doing the second anastomosis. Clinical outcomes, patients got better. You can see the improved MRS over time. This is the mathematics of it, which if you read the paper, it is in the supplementary material. If you're interested in measuring, you can actually measure vascular resistance in each segment of the circuit by using Ohm's law and Poiseuille's law. I will, if you read the paper, you look at you can see the details there. These are the formulae, and these are the formulae for it. So having done that, I realized that I need to introduce two new concepts when you do a 1D, 2R. By getting the ratio of CFI final by CFI initial, that is what I'm calling SARA. S-A-R-A stands for Second Anastomosis Relative Augmentation of Flow. So the CFI final was higher in general than the initial, and by how much higher, I would assign to each patient a SARA number. Then there is another number that is useful, what I'm introducing, the SASI, Second Anastomosis Sink Index. You get that by the ratio of final flow in the second anastomosis divided by the total final flow. So what does that tell you? That tells you how much sink effect the second anastomosis created. So that's a SARA and that is SASI. Easy to remember. It's almost like a name. So this is your typical case of 1D2R. And this is the only case that occluded late, and he occluded bilaterally. I did 2 bypasses, and he was patent on the right side, he was patent on the left side, and at 1 year follow-up, both bypasses closed off, but because he developed vigorous indirect collateral. And he remained completely asymptomatic in spite of losing both sides bypasses. It shows you that it's really not a technical problem, it's a biological, it's not a problem really, it's a biological hemodynamic effect. So here is my summary of what I like about the 1D 2R. You can avoid dissecting the frontal branch and create skin necrosis and adding time to the surgery. The problem is, if you're not very experienced, you injure the STA, then you lose the entire double anastomosis. So I don't recommend it as 1D 2R for the beginner. I think you need to have done a few bypasses first. And it's not suitable if the STA is really very small. You don't want to rely on a very small STA with low flow to do a double anastomosis. And certainly there is no need to do a 1D 2R if the STA bifurcation is high at the level of the craniotomy. You might as well use both STA branches since they are in the field of your surgery and does not require extra dissection. I'm going to skip that. I've already said it, the importance of having a short anastomosis and as big a radius as possible. And in my 21 patients, the mean SERA was 1.79, that's quite high, and mean SASI was 0.4, indicating 40% increasing flow by the second anastomosis. And my conclusion is 1D 2R is very useful because of all the things I mentioned. And my overall conclusion of my whole talk is, please don't give up direct bypass surgery, but select your patients very well. If in experienced hands, it has very high immediate patency rate, and you can achieve, and by measuring flow intraoperatively, you can learn a lot. I do it for almost every cerebrovascular case, aneurysms, high flow bypasses for tumors and so forth. You learn a lot in addition to the ICG. I cannot fully explain the CFI discrepancy between my series and that of Sherbel and Amin Hanjani, but I believe it's due to their use of concomitant indirect bypass. I don't use indirect bypass, so I cannot make a conclusion about its usefulness, but we know from the literature that you certainly do not achieve the same degree of perfusion as you do with a direct bypass. And I encourage you to enroll atherosclerotic patients in a registry if you're going to operate on them, and make sure you understand their physiology pre-op, because there is still a role, as I showed you, for direct bypass surgery in atherosclerotic carotid occlusion cases, unlike what the COS pretends to conclude as an overall blanket statement. And I thank you for your attention, and I stop sharing my slide.
Thank you very much for such a wonderful lecture, Dr. Morcos. I'm sure all the audience has learned from your robust experience. Right now, we have a few questions from the public that I want to read to you. The first one is, how or which criteria do you share with your neurology colleagues to select a typical cerebral ischemia patient to be referred to you for cerebrovascular insufficiency studies as a bypass candidate?
Well, I work very closely. We have a large group of stroke neurologists here. And luckily, we have the same philosophy. They too agree that the COS study results should not be generalized. So the typical patient that they would refer to me would be somebody who has recurrent TIAs or a stroke or watershed ischemia with poor VMR, vasomotor reactivity study by transcranial Doppler, and a poor CT perfusion or MR perfusion, who are on antiplatelets, who have maximized their medical treatment and maintaining their blood pressure. If they fail that, and of course with an appropriate angiogram that shows Moyamoya or an occlusion or severe stenosis, they will refer them to me and we'll discuss them, and I will bypass the patient.
Okay, thank you. Ansh Goyal asks, does combined bypass, direct plus indirect, offer any advantage over direct bypass alone? Is there a situation when combined bypass will be beneficial?
Well, my data, as I discussed, really, I partly answered your question while I was talking, but I've only used indirect once because I could not get the artery to the recipient artery to be large enough. So I cannot comment on its usefulness. You look at studies like the UIC studies, it seems that their long-term patency rate is lower, but I don't know if it's because of the indirect bypass. So my Chinese and some of my Japanese colleagues do use. I don't know if you have a talk in this conference by my friends from Japan or China. Of course, my good friend Bin Shu in China has gigantic experience to share. He uses combined. It's more surgery. It's a bigger flap. My data suggests that you don't need it. I mean, my results are really very good with relatively simple direct bypass.
Okay, thank you. Dr. Torres from Bogota asks, in which cases do you use the so-called high-flow donors, like radial artery or saphenous vein? And which of the two, radial artery or saphenous vein, do you prefer?
I never use, and you should never use so-called high flow for ischemia cases. You will have a hyperperfusion syndrome, and a patient will have a massive hemorrhage. I learned that very early on by doing it on an elderly woman who did not have STA. So I never use so-called high flow for ischemia cases. I use, by the way, again, you probably will, if Fadi Charbel has not said it, he often says it, and I agree with him. We should stop using the terms low flow, medium flow, and high flow, because the STAs, as my data even shows, I have an STA cut flow in one case of 160 cc per minute. That's an STA. So we cannot say STA is low flow. So we should say, my suggestion is to use the word capacitance. Low capacitance vessel, medium capacitance radial artery, and high capacitance is saphenous vein. So I use saphenous vein and radial artery for aneurysms and skull-based tumors that need a bypass. In general, many aneurysms, STA is enough. Always think STA first and go to your other options if STA does not supply enough flow or there is no STA available.
Okay, thank you, Professor. If you don't have a SPECT perfusion available to do diamox perfusion studies, which study technique do you feel is the most sensitive to detect cerebrovascular insufficiency?
Well, I mean, you have a choice. Hopefully you can get CT perfusion or MRI perfusion. I don't think that one is superior to the other. I've used both equally. But we are very biased towards using vasomotor reactivity. Of course, PET, oxygen 15 PET is extremely expensive and not available. I don't have any experience with it myself, but that's what was used, of course, in the COS study, but that's not practical. So I would suggest CT perfusion, MR perfusion, and simply get a technician. If you work with stroke neurologist or even in your department, a technician who can do transcranial Doppler and simply modifying the CO2 in the patient. It's a very simple formula to calculate VMR as a percentage.
Okay, Professor, thank you. Do you use anticoagulation intraoperative or postoperative? If so, for how long?
No, if you mean heparin, I don't use heparin for simple STA, MCA bypasses. I use heparin intraop for saphenous veins, radial artery, skull-base tumor bypasses, complex aneurysm. I've had no need to use heparin, but I absolutely insist on, of course, using aspirin pre-op, intra-op, post-op. I never skip it. Essentially the only two surgeries all of us should do while the patient is taking aspirin without stopping it is, of course, carotid and arterectomy and STA-MCA bypass.
Okay. Humberto Madriñan from Bogota asks, is there any role for vascular endothelial growth factors or cytokines in modulation of vascular growth or collateral formation to compensate ischemia?
I'm sure there is a role. I don't know that I can easily explain it, but there has to be a role. It's been well documented in various neovascularization models.
Okay. How long should you take during the arterial bypass?
How long should you? Well, hopefully you get faster over time. If you go back to it's an interesting question. If you go back, go pull the paper on the COS study results and look at that table of average length of occlusion time. Remarkably, I think it was very high, very long. It was 45 minutes. Now, and by the way, in the subgroup, go back and look at the COS paper. In the subgroup of the COS patients who ended up with complications, it was 55-minute occlusion time. Now, I am not saying that long occlusion time was the cause of the strokes, because actually statistically it was not significant, but there is a trend. I am surprised. You look at the list of, we were not in the COS study, our center. There were, of course, excellent surgeons, highly qualified experts. So I think it's too long. My fellows take 30 minutes to do, a non-complicated bypass. Real experts will probably take 20 minutes. Yes, if you're Bin Shu Bin in China, he tells me his record is 5 minutes. I've never been able to do 5 minutes myself. I've done 15 minutes. But I fish mouth, I make the arteriotomy longer. The time doesn't really, it does matter if you're going to stay an hour and longer, but the SSEPs have not changed, as I showed you in my data. So 20, 30 minutes is good.
Thank you, doctor. Last question. Is cerebrovascular reactivity index important for evaluation of donor or recipient sites for bypass surgery?
Cerebrovascular reactivity is important to select the patient, not doesn't help you choose the donor or recipient. No. It's to select the patient to indicate surgery versus no surgery.
Okay, Professor. On behalf of the CIEN, I would like to thank you again, Dr. Morcos. This has been a wonderful lecture. We are really grateful and honored for your participation in the 2021 IWBNC.
Thank you very much. Goodbye, everybody.
Bye, Dr. Morcos. For all the audience, keep in mind this lecture will be available in our website starting next week. In a few minutes, we will have Dr. Nasser Al-Gandour doing his lecture, Neurosurgical Education in Egypt and Africa. To get the link for this upcoming conference, please follow the link pinned on the chat screen. Check the program schedule on our website, sciencehouse.com. Thank you.